It's in pathology. Today is November 14th and we have talk on a very interesting topic, that is urine cytology. Today's session will be chaired by Dr. Mayuri Trivedi, who is a professor of nephrology in Sion Hospital, Mumbai, and Dr. Reetesh, who is a consultant nephrologist in Sion Hospital, Faridabad. We have our presenter, Dr. Alok Sharma, the consultant nephropathologist in Dr. Lal Path Laboratory Private Limited, New Delhi. So we have 8 participants, various medical colleges of Asia as well as abroad. So I would like to request the students to introduce themselves one by one.
Myself, Dr. Akshay Manekar. I am from Patna Medical College, second year PG resident.
Good evening, everyone. I'm Dr. Sion Limbu. I'm from BP Corella Institute of Health Sciences, Nepal, and I'm a second year pathology resident.
Dr. Vaishnavi.
Good evening, I am Dr. Vaishnavi from Sri Siddhartha Medical College, Tuмкuru, Karnataka. I am a second year postgraduate resident.
Good evening, everyone. Myself, Dr. Deepa Salvi. I am from Government Medical College, Bhavnagar.
Good evening, everyone. Myself, Dr. Ishita Sood. I'm a second year pathology resident from GMC Guwahati.
Good evening, everyone. Myself, Dr. Survi Dubey, and I'm a second year resident at Jawaharlal Nehru Medical College, Ajmer.
So the students will be interacting with Dr. Alok Sharma and attendees, they will interact in the chat box. They will write their comments and moderators will connect with Dr. Alok Sharma. So I'm Dr. Bonita Bora, consultant pathologist from Assam. I'm moderating the session along with Dr. Poonam Sharma. She's an assistant prof in the Department of Pathology, Jammu. Webinar hosts are Dr. Anita Borges and Dr. Sumit Gujral, sir. So there are a few reminders for the attendees. Please do not send any annotation request to the presenter. Here are disclaimers for the program. Few more disclaimers. And I'd like to announce about the upcoming talks. We have from the next 16th, from the next lecture, we have lectures on molecular diagnostics and techniques, starting with the molecular diagnostic cancer of solid tumor. That is on 16th of November by Dr. Rakesh Damde. And on 21st of November, we have our lecture on molecular diagnostics of cancer, hemato-oncology by Dr. Nikhil Patkar, Actrek, Mumbai. So now I'd like to invite our presenter, Dr. Rakesh, Dr. Alok Sharma, sir. So, sir. Hello, sir.
Hi, good evening, everyone. So we are back with slide seminar, and this is the most interesting part. So I hope the full screen is visible, right?
Yes, sir.
Okay, great. So we are back with the cases post Diwali. Hope all of you had a great Diwali. So I think there are 6 cases in total. So we'll go one by one, and we'll try to learn about each and every these clinical conditions based on our findings in urine cytology and what additional tests or investigations we do come to a clinical diagnosis. So, okay, so this was the case 1. It was shared with the students earlier. And what is I'll ask once I'm through with the case and where I want the diagnosis, I'll ask you guys to. So it was a 10-year-old guy who had 1+ urine protein, and it was detected during OPD visit for a suspected UTI. But on repeat examinations after 2 weeks of follow-up, showed trace proteinuria and persistence of hematuria. Didn't have any other complaints, and there was no other family history of renal disease. Hematuria and trace proteinuria was the clinical. was the urinary findings for this child. There was very little urine trace albumin, but a lot of RBCs. Some nephrotic proteinuria. Rest everything appears okay. ANA anti-dsDNA is negative, and complements are also within normal. So the salient finding here probably is RBCs in urine or hematuria with trace subnephrotic minimal proteinuria. Okay. It was the urinary sediment examination which was given. You can go through this. You can see there are some findings left side, some findings on the right side of the picture. And these are phase contrast or images of the urinary sediment. Unstained phase contrast images. Then this patient also underwent a renal biopsy. Right. So since the hematuria was persistent after the urine examination and all the tests, there was a renal biopsy which was performed, and this is the light microscopic picture of the renal biopsy. And then immunofluorescence was negative, so there was no immune deposits on immunofluorescence. And this is what we found on the electron microscope. The EM was also done for this child since he had proteinuria, nephrotic proteinuria hematuria, and these were the findings. Another image from the electron microscopy, right? So what is your diagnosis? So what I'll do is I'll speak to the students one by one. So who will go first? Akshay, can you come in and summarize what has been said and try to do a probable diagnosis?
There is a 10-year-old child with minimal proteinuria, 1 plus proteinuria, which was resolved on antibiotics. And there are evidence of hematuria. In urine sediments, we have cremated RBCs. Dysmorphic RBCs is seen in urinary sediments.
So are
In
these
renal
crenated or are these dysmorphic? So there is the difference, right?
dysmorphic.
Okay, fine. Then
on renal biopsy, it looks like a normal renal biopsy. There is no evident findings in this biopsy.
okay,
And,
can you identify which stain is there in this particular image?
Fast stain.
Very good. So how do you identify that? What you can do is you can look at the Bowman's capsule and the tubular basement membranes. They'll stain reddish magenta color so that you can add. So you won't find this in HG or any other thing. Very good. Okay. IF was negative. And what do you find here? Okay, what do you find here?
There is loss of podocytes podocyte food processes, loss of podocyte food processes.
And this one? Same thing. Okay.
Same thing.
So anything in the GBM, does it look normal to you? Somebody else, Sion probably. Can you add to what Akshay has already told?
Sir, the podocytes, they look like they had been fused, and there is a little effacement as well, and most of the podocytes appear to be fused.
And what about the urinary sediment? Do you agree with what Akshay has told?
There are dysmorphic red blood cells, like in the second picture, where we can see the
So what
the
dysmorphism
spikes.
are you seeing?
I beg your pardon?
No, what kind of dysmorphism are you seeing there? Can you elaborate on the dysmorphic part of it?
Yes, I'm not sure about the first picture, but the second picture, it looks like the one of the red blood cells is kind of has spikes, like the cross, like the Maltese cross, the one that is in the like 11 o'clock. So it looks like dysmorphic RBCs.
Okay, fine. Maybe we can call one more student to Vaishnavi. Vaishnavi is there, right? So Vaishnavi,
Yes,
can
sir.
you just, is there any difference of or addition to what Akshay and San have already told? Do you have anything to add here?
Sir, here glomerular basement membrane is looking like it is thinned out, and there is loss of podocytes also.
So fine. So rest everything you agree, right?
Yes, sir.
So can somebody come up with a diagnosis here? Deepal, can you summarize and just give a diagnosis here? I think
So I can exclude the minimal chain disease.
minimal
10
tail
years
disease is not
ago,
here in question because the patient does not have nephrotic syndrome or proteinuria, right? The child's problem is of
no
hematuria.
+3 +4 proteinuria is not present. Only +1 proteinuria.
Yeah,
So
so
minimal
change, we
can
are not talking
exclude.
about minimal change here at all. Okay.
So that's a diagnosis.
So you are giving an diagnosis of exclusion. Is it how? Okay, no problem. So I think at this case we'll just summarize and I'll let you know exactly what's going on here. So as all of you have correctly pointed out that there are definite dysmorphic RBCs here. But always remember that this child has got hematuria. It doesn't have much proteinuria. You know, barely any proteinuria. So with that in mind, you should progress ahead with how you evaluate that case. One thing is sure, this child definitely has dysmorphic RBCs. So what is the type of hematuria? It is a glomerular hematuria. Last time in the class also. So when you have a significant number of 70 or 80% dysmorphic RBCs, it's most likely glomerular hematuria, right? Glomerular hematuria means there is some problem with the glomeruli, what is happening there. It is causing hematuria. Right? The light microscope is absolutely normal, so there is no proliferation or anything to cause hematuria, no crescents, no necrosis, nothing. IF is also negative. So what can cause hematuria in this setting? Normal glomeruli, negative DIF, immunofluorescence, what can cause? So obviously it will not be podocytes, right? So podocytes are not, that is not the primary injury here. So what you need to do here is look at the GBM also, apart from the podocyte. So this GBM is not normal. It has been broken down into multiple fragments. It is showing rarefied areas. And if you look at closely at the GBM here, you can see it is showing some membrane particles, some crisscross appearance. So the entire lamina densa has been broken down into multiple fragments. So that is the pathology here. And one more thing I want to like to point out here. Some of you have said about loss of food processes. So you should remember that food processes do not get lost. They are always there. So what happens? They just misalign. So they fall flat. So that's a process which is called effacement of food process. It is not loss. So the moment you give therapy and if the patient responds to your steroids, the food processes will come back to their original place. They will realign themselves. Okay. So podocytes, of course, they get lost, but the food processes do not get lost. They get effaced. Always remember. So do not call food process loss. Call it effacement if you are not able to speak. Okay. So what was there? So urinary finding dysmorphic RBCs, glomerular hematuria, dysmorphic RBCs. EM is showing GBM collagen abnormalities. Okay. So that is what this child has got. Alport's disease. Okay. So this is how you come to a diagnosis in a case of hematuria, dysmorphic RBCs. You form a differential diagnosis, do urine examination. If biopsy is available, you look at the biopsy, exclude any proliferation, exclude any immune deposits. And when you do an electron microscopy, you will be able to see any structural abnormalities or anything on the glomerular. Okay. Case of Alport's disease. Similarly, you can have thin basement membranes which can cause glomerular hematuria also without any proliferation or any exudation. Same picture, but only when you measure the GBM, they will be very thin. So the normal GBM thickness usually we take in adults is around, mean should be more than 250 nanometer in diameter. In children, it is lesser, it's around 180. Anything which is below this is called thin glomerular basement membrane. Okay. So this was, and just to elaborate on this for your benefit and for the benefit of the audience and people who have joined in. So you need to differentiate the various forms of dysmorphism and other things. So you can have schistocytes and poikilocytes, the elliptocytes, and the dacrocytes. So these are different forms, but glomerular hematuria is of. So this is what you see in a glomerular hematuria. These are the dysmorphic RBCs, where you can see a dog's ear appearance of various types of these small blebs which protrude from the RBC's membranes because of the variations in weakness in the GM membrane. So this is a dysmorphism which you should be looking for in your urinary sediments. Okay? The dysmorphic. Okay. So case 2, can somebody just take up the case 2 and then discuss? I think that will be better, right? Maybe Jyoti is there. Dr. Jyoti?
No, sir.
Oh, okay. So probably then Ishita can take up this case. Dr. Ishita?
35-year-old female complained
Yeah.
of generalized weakness, breathlessness, and exertion since 2 years. No other systemic complaints, no edema. There's history of intermittent passage of dark-colored urine over last 8 to 9 months. She's had 3 to 4 episodes. There is no family history of renal disease. Uh, the urine parameters, there's 2 plus albumin, RBC nil, and pus cells 1 to 2 per high power field. 24-hour urinary protein is 991 milligrams. Urea, creatinine, cholesterol are within normal limits. The patient has normocytic normochromic anemia with hemoglobin of 6.9 grams percentage. ANA and anti-DS DNA are negative. HPS, HE, HCV, HIV are non-reactive, and C3 and C4 levels are also within normal limits.
And this is the gross appearance. So what do you see in the gross appearance?
Pinkish, pink-colored urine.
But if you go back, there were no RBCs in the urine, right? So how is this? So does this give you some clue on the?
So there is presence of hemoglobinuria.
Okay. So what do you find in this? So this is a representative picture of the urinary sediment. So what do you find here?
The heme deposits, hemosiderin pigment in.
Okay. So is this a normal stain or is this some special stain? I told about this in the last class. So what stain do we use? So if you're looking for iron specifically, what is the stain which we use? It's a very commonly used stain, right?
Pulse stain.
Yeah, absolutely. Going forward, when this patient, the renal biopsy was performed, this was the picture of renal biopsy which came to us. So maybe Surabhi, you can just quickly spend some 10 seconds on this picture and explain what has happened here.
So basically here I can see deposition of iron in the tubules, like tubular deposition of iron, which shows that there is some kind of intravascular hemolysis happening, which is in turn causing hemoglobinuria and further going into resulting into hemosideриnuria, and which is getting deposited in the tubules, and it is staining positive for.
So this basically is staining the hemosiderin, right?
Hemosiderin.
So this is pearl stain. You must have heard about it. That pearl stain is a specific. So we can use the same stain in the urine sediment also, right? And the same stain we can use in the biopsy tissue also. Very versatile stain which you can use for both the places, and it will give you a very nice glucose. You just have to exclude any contamination here. Just do it neatly. It will give you very good results. So what do you think is happening? And who will come up with the answer there? Surbi, you can only tell. So what do you think was the process going on, and what is your differential or final diagnosis there?
So the patient had a history of intermittent passage of dark colored urine over last 8 to 9 months, and there's this word intermittent here. So basically, it is not happening regularly. So I'm thinking like it's intravascular hemolysis happening, and which is causing hemoglobinemia and hemoglobinuria, and in turn hemocitrinuria as seen in the renal biopsy. And so I'm not exactly sure, but I PNH, paroxysmal nocturnal hemoglobinuria.
Okay.
Like I'm
Anything
more
else?
like
Any other condition where you can think which can cause this? So there are multiple causes of intravascular hemolysis, right?
yes, sir. Yes, sir.
It's not a very uncommon clinical syndrome. A lot of etiologies of intravascular hemolysis, but yes, of course, they will have a relatively common theme of this kind of a picture. And the learning point here was to pay attention to the presence of reddish urine with absence of RBCs in the microscopic examination. So that's a very, very important thing which everybody should know. So if you have this condition where you have red urine, but you are unable to see any RBCs in the urinary sediments, you would always think of any intravascular hemolysis going on, and that should lead you to the performance of pearl stain on your sediment. So that's the second step you do. So sometimes you may make the diagnosis then and there. You might not even the patient might not even be required to undergo a biopsy. So you can make a very good diagnosis there. In case the biopsy is done, again you can use the same stain. By the way, if you look at it under without staining in the routine HE, this will appear as brown granules. It's a very characteristic. I'm sorry I didn't put up that picture here, but it gives all these hemosiderin stain which you are seeing positive in pearls will appear as brownish granules in the HNE stain section. So they're all hemosiderin material. As you have actually told correctly, this patient did have paroxysmal nocturnal hemoglobinuria. It is the most common genetically determined cause of recurrent intravascular hemolysis. All of you know what is the underlying genetic mutation which leads to recurrent hemolysis here. The complement also plays a lot of role in that. So the takeaway message is absence of RBCs in spite of reddish urine, presence of hemoglobinuria, hemocitrinuria, and pearl stain positive adherent tubular epithelial cells evident both in biopsy as well as your urinary sediment, right? So very good, well done. Thank you for the input. Only thing here, you should also read about more causes of intravascular hemolysis. Right? You give a differential diagnosis, which are other conditions which can lead to intravascular hemolysis and can produce kidney injury as a part of that intravascular hemolysis. Okay, fine. So we can move on to the next case now. So we've learned two very important things here. First was a child with isolated hematuria, and finally you made a diagnosis of glomerular hematuria, followed by all the investigations leading to Alport syndrome. Second, you have made a good diagnosis on urinary sediment and confirmed it with all the other investigations. Okay, great. So who will take up this case? Ishita took it last time, right? Surbi, you can take this case.
Okay, sir. So a patient known case of SLE for 6 years presents with rapidly worsening renal functions. ANA and anti-dsDNA antibodies were positive. C3 and C4 levels were low. Nausea and vomiting were present, and there was no edema. Again, coming to the parameters, albumin was trace, RBCs 1 to 2 per high power field, pus cells were again 1 to 2 per high power field, debris was present, and casts were seen in the urine. 24-hour urinary protein was 230 mg. Urea level was 89 mg percentage. Creatinine was 4.3 mg percentage. Cholesterol was 187 mg percentage. Hemoglobin was low, 8.4 gram percentage. Liver functions, bilirubin was 12.1 mg percentage. ALT was 81 international unit per liter, and AST was 109 international unit per liter. HbA1c, HCV, and HIV were non-reactive, and C3, C4 levels were low, that is 67 and 9 mg percentage.
So the salient findings here are hypocomplementemia, right? Liver dysfunction, you can see very high bilirubin here. And rest of the things appear more or less okay, except for debris and cast in the urinary sediment, right?
Yes.
Okay, great. So this was the clinical impression. So patient, of course, does have a hepatorenal syndrome, and patient already has SLE. So the clinician obviously would think of an SLE nephritis in this picture, and of course he also has hepatitis now. So maybe somebody else can describe this urinary sediment. Is Akash here?
Sir,
So maybe
Dipal Salvi is there, sir.
who's there?
Dipal Salvi.
Sir,
Okay,
is
yeah, yeah.
it golden yellow bilirubin cast?
So what do you see here?
Sir, golden yellow color cast are present in urinary sediment.
Mm-hmm.
Patient bilirubin is high,
Yeah.
so bilirubin cast. This is
Okay, great. And then when the patient actually did undergo a biopsy, you would find similar casts in the biopsy also. You can see that golden brown colored. So are you aware of any stain which can be used to detect these casts? Confirm the presence of bilirubin casts.
no, sir.
Okay, fine. So it's a very common, you must be doing it in your routine earlier years of your training also. So the diagnosis you've already made. So whenever you have bilirubin casts in the biopsy and you have bilirubin stain, call it a bilirubin cast nephropathy. But tell me one thing, somebody will answer, maybe you can only ask, that, does this patient have lupus nephritis? People? So does this patient qualify for diagnosis as lupus nephritis?
Sir, he had a hepato and renal both are impaired in this patient. Both organs are involved. So hepatorenal syndrome
Hepatorenal syndrome.
as well.
Akshay, can you do, what do you think? Please come in. Do you think this patient has lupus nephritis?
Yeah.
Okay. So what I'll let you. Can you hear Akshay?
Sir,
Do you think this patient has lupus nephritis?
I have no idea.
No idea. Okay. Perfect. No problem. See, patient has SLE, that is for sure, and also has bilirubin casts in the. So he has a bilirubin cast nephropathy. Look at the previous slide. Glomeruli are not showing any proliferative activity, and DIF is negative. So by definition, there is no lupus nephritis per se. Okay. What is happening here is because of that autoimmune SLE-induced hepatitis, the patient is having bilirubinuria, and those bilirubin casts are damaging the kidney and causing bile cast. So you can diagnose a cast of bilirubin cast nephropathy even by doing urinary examination, right? Okay, fine. So 3 cases done. I think 3 more, and then we'll learn few more things. So the 4th case, who will take up?
Sion is there.
Sion, yeah. Sion, please take up this.
Sure. It's a case of 67 years old male presented with mild pedal edema, generalized weakness, and rise in creatinine. That is 3.4 milligram percentage. He's known case of hypertension, and he's smoker, non-diabetic. Recent history of coronary angiography. Procedure 2 weeks back.
Just summarize the findings here.
Urine shows in 1 plus, and red blood cells of 1 to 2, pus cells 1 to 2, and debris present. 24 hours urinary protein is 1142. Urea and creatinine are increased. Cholesterol is increased. Hemoglobin is 8.4. He's anemic, and liver functions are within normal limits. Serology is non-reactive, and C3 and C4 levels are 90 and 29 milligram percentage.
Are they normal or are they low?
I think they are increased
No,
slightly.
they're normal. Okay, so don't worry.
Oh,
These are normal. So these are normal levels of both C3 and C4. And this was you can go ahead and describe this urinary sediment also and try to identify what's happening here.
so urine shows WBC, white blood cell counts. We can see
Very
the
good.
neutrophils and probably some eosinophils as well. So the second picture shows eosinophil. We can see the orangeophilic granules.
So which stain can you do in urine to detect eosinophils? Is there a specific stain you are aware of by which you can detect eosinophils well in a urinary sediment? Because the routine stains won't work here. So probably you'll need to use
Right.
a stain. So if you attended the last class, you can come up with very good. But he has
No,
answered in the chat.
yeah, I'm not sure, sir.
Okay, so it's a Hensel stain which you use. So you can go back to the previous lecture, have a relook at it. Then you should be aware of which special stains to use in which specific conditions. So in this particular case, the patient has had a history of CABG, and whenever such patients are seen by surgeons or physicians in the post-op period, you will always get specifically urine asking for eosinophiluria, and why is evident in the next case. So somebody can just describe this. Maybe Ishita, you can describe this image. This is a renal biopsy
Yes,
which
sir.
is showing some finding. Can you identify what finding does this image show?
There's a recanalized thrombus.
Okay. So is it what kind of a thrombus is this?
I'm not sure.
So you can see this needle-like things right there.
Yes, sir. Yes, sir.
So what do you think must be? So what do you think they must be? So of course you have identified correctly that this is a vessel. That is, we are talking about a thrombus. And when you have these needle-shaped staining structures, what do they usually denote? Not in kidney, anywhere else in the body. So what do you think these may represent?
The
Cholesterol
cholesterol.
crystal.
Very good, absolutely. So this is an thrombus which you have correctly identified, if you can call it that. It's composed of cholesterol crystals. So and this is and where do you see what is the structure when you see this in a vessel? What is it called? Atheromatous plaque, right? So this is an atheroembolus which is lodged into that vessel, and this is a atheroembolic renal disease. And you should remember this is the reason why the clinician will always ask for eosinophiluria in this patient. What happens when it does a CABG procedures? A lot of these atheromas while doing the procedure get dislodged, and then they circulate in the body. And in few of these cases, they get lodged in the kidney and cause renal dysfunction. And these are called atheroemboli. These are emboli which have been dislodged from their original place by the CABG procedure and have got accumulated at various places and cause a lot of symptoms. So kidney is one place where there is a propensity for these atheroemboli to get lodged. And because they elicit a allergic kind of a reaction, and that is why you get eosinophils in the urine. Right? So the whole idea of doing eosinophilia in the post-op period is to get an indirect evidence or suspicion of any atheroemboli so that they can be taken care of. So there is a clinical algorithm which they follow to tackle these cases. But first step is to diagnose whether any allergic reaction or eosinophilia is being used because of atheroemboli diagnosis. It's a beautiful thing, right? The procedure has happened somewhere else, CABG, but who's suffering? The kidney. And you are supposed to make the diagnosis based on the urinary finding, and if possible, if at all the biopsy is required, there you can pick up the finding. Okay, so this is an atheroembolic renal disease post CABG procedure. Always remember this. So it's a very important clinical utility of a clinical bedside urine examination is in this particular. Okay, great. So going on to probably the second last case, who has not taken any case till now? All of you have participated.
So Vaishnav is left.
Vaishnavi. Okay, fine. Vaishnavi can pick up this case.
Yes, sir.
Yeah.
45-year-old male, non-diabetic, non-hypertensive, BMI is 42, gastric bypass surgery has been done 2 weeks back, complaints of nausea, vomiting and generalized weakness, detected with renal dysfunction. Parameter showing albumin 1 plus, RBCs 2 to 3 per high power field, puzzles 3 to 4 per high power field, debris present and crystals present. Creatinine is 4.1 mg percentage and urea is 91 mg percentage. Cholesterol is 157 mg percentage. Hemoglobin is 12.5 grams. Liver functions are within normal limits. Serology is non-reactive.
What do you see in this picture? You can just go ahead and describe this quickly.
Sir, in urine sediment, there is calcium oxalate crystals, which is enveloped in shape, which is increased in number, I think.
Basically, there is increase. So as I told you in last class, this may not always be abnormal. So depending on pH, you can get oxalate crystal, but then you have to correlate the entire clinical picture, right? So this patient did not have resolution of renal functions. Biopsy was performed. So this is what was seen in the biopsy. So somebody can explain this biopsy? Akshay, maybe you can?
Yes, sir.
Yeah. Quickly just tell us, what do you see in this?
Glomeruli. Firstly, I like to comment on glomeruli. Glomeruli are shrinked.
Okay. Anything else just next to the glomerulus on the left side?
There are crystals.
And
These
what is the
calcium
right side
oxalate
image?
crystals are seen in bluish in color, and it is seen in polarized light. This shining calcium oxalate
Shining. So
crystals are seen.
Can you give a scientific term for this shining? Reptile birefringent, right? Shining, don't call shining. So shining is something when you reflect on something a right red light. So this is a specific scientific process. Okay. So on a cross polarized light, these are birefringent or okay. Okay. So does it have anything to do with this morphology, that birefringence? So if I was to polarize this particular image slide, will the crystals appear same as in the biopsy? They will, right? So are you aware of any other oxalate crystals which will not do this? I told you in the last class. So there are two types of oxalate crystals. Yeah, monohydrate and
Monohydrate, dihydrate.
So which is this one?
Dihydrate.
Okay, fine. So they are the ones who polarize. Right? So what will be your diagnosis in this case? And why has it happened? Importantly, why has this patient landed up with this problem?
Urate nephropathy because of the gastric bypass surgery. There is decrease.
But there is no urate. This is not urate, right? What did we just speak about?
Oxalate.
Oxalate.
So if you look at the clinical history, what had happened? There was a gastric bypass surgery.
Bypass surgery.
So post gastric bypass, because of the what has happened to the after the gastric bypass surgery, what has happened? What do you think has happened?
There is decreased excretion of the oxalate from the body, so increased amount of oxalates are present in the body.
You need to read this up. So is it increased secretion or decreased absorption? So all these things you should be aware of before coming to a clinical diagnosis. And this is how you link the things together: clinical history, urinary findings, clinical findings, urinary sediment, and then finally the biopsy findings to give you a diagnosis. Okay. This is a secondary hyperoxaluria because this is secondary to a gastric bypass surgery, and which is why you have been able to diagnose it, right? Okay. So let's take this up. Deepal, can you take this up?
54-year-old diabetic patient complained of fever and reduced the urine output for 15 days. Urine wet mount examined in the emergency department shows the.
What are these? So what this is not a polarized light. You have just lowered the condenser here so that you can see a contrast between the background.
They are the WBCs.
Yeah, very good. So large number of WBCs, full field, right? Packed with WBCs.
Plenty of WBCs.
Yeah, and this patient did not improve, and the kidney biopsy was done after a few days because of creatinine, and this is what it showed. So what do you see here?
Kidney biopsy done after 6 days due to the non-resolving renal dysfunction. Create is high, 6.8 milligram percentage.
So what is this you are seeing in this particular picture? This is an HE stained section of renal biopsy.
For My slide is not showing up to negations.
Okay. Maybe, okay. No problem. Ishita, can you tell us what's there in this particular image? Ishita?
Plenty of inflammatory
Inflammatory
cells.
cells.
Yeah, fine. A lot of inflammatory cells. And exactly what you were seeing, there's a lot of neutrophils. Neutrophil cast, neutrophils in the interstitium, they're all eating up all the tubules. It's a
Damaged tubules.
kind of, yeah, damaged tubules with the intense infiltrate of neutrophils. So what is this? This is a,
Acute interstitial
Pyelonephritis.
nephritis.
no, that is a
Acute
difference.
pyelonephritis.
Yes, so in
Acute
kidney,
pyelonephritis.
very good. So this is an acute pyelonephritis. So always remember in kidney, when you have neutrophils, you think about infections. Unlike other organs where you call different other things, interstitial nephritis in kidney is predominantly composed of mononuclear cells, lymphocytes, right? Unlike in other organs where you call neutrophils as itis wala angle comes in. In kidney, whenever you call pyelonephritis, it is neutrophils. Interstitial nephritis is composed of lymphocytes. Always remember. Okay. So this is the reason I wanted to bring this case up. So abundant neutrophils and pus cells and extensive destructive neutrophil infiltration in the urine parenchyma. So this is an acute pyelonephritis which you can very well examine a urinary sediment and make a diagnosis. Okay. So this is how we have done today. We've seen a spectrum of cases, all 6 different clinical syndromes, different presentations, different urinary sediment examination. Based on amalgamation of findings, we have come to a diagnosis which will eventually help the clinician in managing them. Okay. Thank you. Very well done. All the students have done really well and given good answers. Thank you so much.
Thank you, sir.
Thank you.
Thank you, sir.
So maybe the moderators can.
Thank you so much, sir,
Thank you
for
so
this
much.
very informative talk. Both your talk on urine cytology and this seminar as well have thrown much light on a topic which is very less discussed. Sir, I would like to share my screen for the upcoming talks. So many students are giving praises to you in the chat box.
I hope they
Sir,
learned
there is
something.
a
Yeah.
So there's a question, won't pus cell casts be there as well always in urine in the last case?
So if the question means that pus cell casts are normally seen, then the answer is no. You can see usually less than 5 hypertrophy, but any pus cell cast is an abnormal finding always. So you can take that as a learning lesson. Any RBC cast or any WBC cast, if you see, is always an abnormal finding, and you should work on it further to identify what is going on with that patient.
Right, sir. So, sir, just before we end the talk, brief about the upcoming talk that we have on this Thursday. So we'll be starting with the molecular techniques, and the first talk on molecular techniques is molecular diagnostics of cancer, solid cancers. And the faculty who will be in charge of this will be is Dr. Rakesh Damde from the Center of Oncopathology, Mumbai. And thank you, Dr. Alok sir, for this very informative talk. Thanks to all the students for their participation.